Hello everyone, good evening. Hope all are doing good. It's been almost a week since I met you all through a video. And first of all, I would like to thank all of you for giving such a overwhelming responses. The team was excited to receive such responses, such positive feedbacks and comments. And keep supporting us throughout this journey. And if you have any suggestions or feedbacks you want us to include videos of other subjects at your convenient time, you can probably let us know. Any kind of feedback or suggestion is welcome. Ultimately, you are the audience. Whatever video we are doing is going to serve benefit to the volunteers as well as to audience like you all. So I wish you come with lots of suggestions and feedback so that it will motivate us to do even more better. With that said, I would like to start with today's topic. It is on elbow joint. Um, Second most important joint in the limb. First was shoulder joint, which was dealt by Dr. Samyukta. And today we are going to look into elbow joint. From university point of view, not an important question. You have got only one important short note, that is blood supply around the elbow joint. That is very frequently asked in a short note. But clinically, if you take, elbow joint is a very important joint. Now, most common joint to be dislocated is elbow joint. The first most common joint to be dislocated in adults is shoulder joint. The second most important is the elbow joint. So you step into orthopedics department in your college hospital, you will definitely be given a case of either a shoulder joint dislocation or an elbow joint dislocation, hip joint or knee joint. These are the four important joints that you must know in and out. That is why I have come for this session, right? So first let us talk about the anatomical aspects of elbow joint. That is very important for you to understand the clinicals. And when it comes to clinical aspect, I have put only radiographs, right? I will try to explain some, even I am not a radiograph expert, but I will try to explain you the implications of understanding anatomy. So if you know anatomy, yes, you will be able to interpret the radiograph to some extent. So I am going to give you that path of understanding radiography, right? So I hope you follow the session and just listen as if you are going to deal with a patient, right? You need not take notes and no sit and prepare for your exam kind of thing, but you are just going to imagine that a patient had come with some elbow joint disorder and you are going to treat the patient. Yes, I don't want to give a introduction more than this. It had been a very brief introduction. So let us get into the topic. So as Samyukta said in the last video, any joint you study, it should start with first type of joint, followed by articulating surfaces, ligaments, relations, movements, blood supply, nerve supply, clinicals. My interest is definitely this, right? Now, if I want to know this, I need to know all these, right? Yes. So let us get with the type of joint. Yes, the joint that we dealt last time is shoulder joint. It was ball and socket types. What is the meaning of ball and socket? Yes, it was a multi-axial joint, right? The shoulder joint was a multi-axial joint because it was a ball and socket type. But here, if you take it is inch type, right? When it is inch type, yes, it is not going to allow variety of movements. If you take shoulder joint, yes, flexion, extension, abduction, adduction, rotation, everything is possible. But if it is an inch type of joint, yes, the movements are very limited. So only flexion and extension are possible. Right, so it's an inch type of synovial joint and it is also a uniaxial joint. Right, so these are the 2 points that you must know with respect to the type of elbow joint. Right. Next, so before getting into the joint, understanding the articulating surfaces, of course, we have to know about the articulating surfaces, right? I want to highlight on few important landmarks, just the name of the landmarks, not into the details. Now, if you take, this is the anterior view of the humerus, right? This is the anterior view. So let me write it as AV. So if it is AV, meaning it is anterior view, and this is my posterior view. So if you take anterior view, I want you all to focus on certain landmarks. As these 4 landmarks that had been mentioned. Yes, medial epicondyle, and here you will be having the lateral epicondyle. Yes. Now, 2 important thing is this one is the capitulum. Capitulum is like a projection on the lateral aspect of the lower end of the humerus. What is capitulum? Yes, it is a projection seen on the lateral aspect of the lower end of the humerus. Right, so this bulged one is your capitulum. Then you have got a green color one, again a landmark, that is called trochlea. So this trochlea is going to extend both on the anterior aspect and also the posterior aspect, right? So you have got something called capitulum, you have got something called trochlea, right? So these two prominence are going to form the articulating surfaces, as these two prominence are going to form the articulating surfaces of the elbow joint. So which means it is going to get attached to its corresponding bones, right? So that is why it is called as the articulating surfaces. So two important landmarks is it's the trochlea and the capitulum. And along with it, you have got some fossa, that is called, one is the coronoid fossa, another one is called as the radial fossa, another one is called as the olecranon fossa. Yes. So what are these fossa? Now, if you take in the ulnar bone, we have got two processes. One is called as the olecranon process. Another one is called as the coronoid process. So these are all the articulation surface. Again, these are all some processes, some bulgings from the ulnar bones, right? So these processes or the bulgings has to attach to the counter bone, that is the humerus. Are you able to get my point? So these processes should find a place on the humerus to get attached. That is when the movements are possible. So the olecranon process is going to attach to a fossa called olecranon fossa that is located on the posterior aspect of the humerus. Similarly, the coronoid fossa is located on the anterior aspect of the humerus where coronoid process of the ulna is going to attach. And radial fossa is for the attachment of the head of the radius. Very simple. So you have got three fossas, two landmarks or two prominences in the lower end of the humerus, out of which the two prominence, trochlea and the capitulum, is going to form the articulating surface. Yes, this much of knowledge is very, very important for you. Now let us get to this picture, a very good picture to know, understand the articulating surfaces. So if you take, as I told, the articulation or the structures that are going to take part in articulation is number one, yellow color, I mean this bulging one, laddu one, that is capitulum. Another one, a bow tie like structure, that is trochlea. The another one is it's the head of the radius. The other one is you have got something called as the trochlear notch of the ulna. Yes, we saw, right? Trochlea is a prominence on the lower end of the humerus which has to get a place for it has to get a place to sit. That is the trochlear notch in the ulna. So these are the four important articulating surfaces I can see. So if you take, I have got humeroradial articulation. So the humerus bone is going to get attached to the radial bone through some articulations. So what are the articulations found? Yes, it is formed by the capitulum at the head of the radius. Yes. So on the radial aspect of the elbow joint, how it is formed is the elbow joint in the radial aspect or the lateral aspect is formed by the articulation or the joint between the capitulum and the head of the radius. So this is one articulation that is found right on the lateral aspect or the humeroradial aspect. And similarly in the humero-ulnar articulation, which means on the medial aspect, that is the relation between or the connection between or the joint between the humerus and the ulna, as it is formed by the trochlea and the trochlear notch of the ulna. And along with these two articulations, we have got one more articulation that also plays a role, that is the superior radio-ulnar articulation, which means the superior aspect of the radius and the superior aspect of the ulna is going to form a joint. Yes, that is the superior radio-ulnar articulation. So if you take that is formed by head of the radius and the ulna is going to have a notch or a depression. Can you appreciate this depression here? As this is the radial notch of the ulna. So this is going to articulate. So if you take, one has got the prominence, another one has got a fossa or a depression or a notch for it to sit on it, right? So I've got three articulation. The first one is humeroradial, that is between the capitulum and the head of the radius. Why am I repeating? As all these are going to form very important role in the clinicals. The other one is humero-ulnar articulation between the trochlea and the trochlear notch of the ulna. The third one is the superior radio-ulnar joint formed by the head of the radius, is head of the radius and the radial notch of the ulna, right? So these are the three articulation surfaces, right? Very clear? Yes. Next one, let us get into the ligaments. Now, unlike shoulder joint where you would have seen so many ligaments like glenohumeral ligament, transverse ligament, coracoacromial, coracohumeral, here you have got only few ligaments. Always the first one is like the king in the chess. Every joint will have something called as the capsular ligament. Right, so every joint has got a joint capsule as the outer covering, like how a boundary is must for a stadium. Capsule is like that, right? So the joint is the stadium, and you have got the capsule that is going to form the outer covering, right? So every joint will have a capsular ligament, and important named ligaments of elbow joint is there are two in number. One is the medial ligament, or I call it as ulnar collateral ligament. Medial ligament or ulnar collateral ligament. Ulnar, so which means it is on the medial aspect. So medial ligament. Next one is the lateral ligament or the radial collateral ligament or the lateral ligament. Yes, very simple. These are the three ligaments that are present. Yes, so let's get to see them one by one. Now, in the textbooks, we have got a diagram like this. Can you appreciate these diagrams? Yes, this is what is given. Now, if I'm going to explain you with this diagram, you might find it difficult to understand the capsular ligament. So for which I want you all to observe this picture carefully. Yes, can you appreciate this is the capitulum, this is the trochlea, this is the coronoid fossa, yes, this is the radial fossa, and here we'll be having the trochlear notch, and this is the coronoid process. Yes, you have got lots of landmarks that we have discussed. Now, what I want you all to understand is, yes, you have got some pockets. Right? These are all the pockets into which this prominence are going to sit. Right? So this entire thing is what is going to form the joint. Right? This entire thing is what is going to form the joint. Now, if you observe the picture carefully, this lining that I am showing here, right? I have put a dosa here, right? This is the dosa. And if you just get along the boundaries of the dosa, yes, this one, these lines here. So this entire one is what is going to form the capsule. So this is going to sit inside this. Yes, it's going to sit inside. So my capsule is actually the outermost boundary. Yes. So if you would see in the capsule, can you name the structures that is related to the capsular ligament? Yes. Coronoid fossa, medial epicondyle, trochlea. Then can you appreciate here? Yes. Medial epicondyle, lateral epicondyle, all your fossas here. Then if you come to the ulnar bone, you have got oligrenon process, the coronoid process. Then if you take the head of the radius. So this is how the capsular ligament goes. Right? Just have this picture in your mind so it becomes very simple, right? Now, first, I am going to explain you this portion, how the capsular ligament is present in the humerus. So I have given the anterior aspect of the humerus, and this is the posterior aspect of the humerus. Now, if you take the anterior aspect of the humerus, can you appreciate the picture? Yes, I need not write anything. This is the capsular ligament. So it starts from the medial epicondyle. Yes, then it goes upwards. So when I say medial epicondyle, it is also related to trochlea. So it starts right from the trochlea and the medial epicondyle, because the trochlea is going to form the humero-ulnar articulation, right? So trochlea along with the medial epicondyle, then it goes upwards. Yes, it goes upwards. Then it is related to two fossas, the coronoid fossa and the radial fossa. Then it comes downwards to along the lateral aspect, where it is related to the capitulum and the lateral epicondyle. Related to the lateral epicondyle and the capitulum. And posteriorly, if you take the capsular ligament, is also going to extend along the oligrenon fossa also, right? So it's like capsule, right? It is a rounded structure, so it is going to extend even on the posterior aspect. So it is related to the oligrenon fossa also. So if you take in the humerus, it starts from the trochlea and the medial epicondyle, covers the coronoid fossa and the radial fossa, and then it comes along the lateral epicondyle and the capitulum. During its course of its journey, it is also going to cover the oligrenon fossa. So this is how the capsular ligament is related to the what? The humerus, right? Now coming to ulna. So again, I want you all to observe this picture. So this one is done. So you are very clear about humerus. I do not want to repeat. Now coming on to the ulna, yes, can you appreciate oligrenon? Then you have got the coronoid process. Then you have got the head of the radius. Now if you take head of the radius, I want you all to know one structure alone here. What is the structure is it is something called annular ligament. What is that called? It is called annular ligament. Annular ligament is nothing but again a ligament that is going to join the head of the radius with the radial notch of the ulna. If you remember, I told you one of the articulating surface is the superior radioulnar articulation that is formed by head of the radius with the radial notch of the ulna, right? The same thing here. So if you take the ulnar ligament is going to connect the head of the radius with the radial notch of the ulna. So the capsular ligament is going to extend along the oligrenon process. Then if you take, it is not going to wound around the entire coronoid process. Can you appreciate this is the entire coronoid process, but it is not going to wind around the entire coronoid process. It is going to wind only around two margins. What are the margins? Yes, it is the anterior and the medial margins. It is along the anterior and the medial margins. So if you take the capsular ligament in the ulna, it starts covering the oligrenon process. Then it comes downwards. It covers the medial aspect. So this is the medial margin of the coronoid process, and this is the anterior margin of the coronoid process. So the capsular ligament covers the medial and the anterior margins of the coronoid process, and it goes along the head of the radius where it is related to the annular ligament, and it completes the capsule. How very simple. So it starts here, it goes like this, then along the posterior, it enters the posterior aspect, and it is going to come along the oligrenon process, then the anterior and the medial margins of the coronoid process, then along the head of the radius. Just see this picture as oligrenon process. So from the posterior aspect, the ligament had come, it is going to cover the trochlear notch, and here you are having the coronoid process, and it is going to get to the annular ligament and the end of the radius, and it completes a very beautiful capsular ligament. Right. What is important? So why should I know all this? The course, all this. You have to know that the capsular ligament is thin at the anterior and the posterior margins, but it is strong or thicker at these sides. So which means now I have got a risk of dislocation either anteriorly or posteriorly. I cannot have a sideways dislocation of the elbow joint because my capsular ligament is thick, right? It is going to give a strong force so that it is not possible for dislocation. So my possible thing is either anterior or posterior dislocation, but again, I'm going to eliminate one more chance here. Okay, we'll see in the next slide, right? So this is about the capsular ligament. The next one is, this is my, so if you take, this is the medial epicondyle, this is my ulna. So this is my ulnar collateral ligament or the medial ligament, and this is my lateral ligament or the radial collateral ligament. So if you take the medial ligament, it is going to arise from the medial epicondyle. So this is my medial epicondyle, and it divides into three bands. It is going to divide into three parts, like how you would have seen the glenohumeral ligament and shoulder joint. The medial ligament or the ulnar collateral ligament is going to be divided into three parts. One is the anterior band, the other one is the inferior band, other one is the posterior band. Now if you see, I told you that the capsular ligament is thin at the anterior and the posterior margins, and I told you now dislocation is possible either anteriorly or posteriorly. But now I'm going to eliminate one. What I'm going to eliminate is the anterior dislocation as shoulder joint. Very rarely cases of anterior dislocation have been reported. Why? Because the anterior band of the medial collateral ligament or the ulnar collateral ligament, which is going to join the medial epicondyle to the coronoid process. Yes, the anterior band of the medial ligament joins the medial epicondyle to the coronoid process. So this anterior band is very strong. It is strongest. So it is going to support the joint from the anterior aspect. So anterior dislocation is very rare, right? So then I have got the intermediate fibers, which is going to lie between the coronoid process and the oligrenon process. So the posterior band, which is also thin here, is going to connect the medial epicondyle to the oligrenon process. So it goes posteriorly, right? So again, if you take, this is thin. Now, can you understand why should I learn ligaments? Is only if I know about the structure of the ligament, I'll be able to tell which side dislocation is possible. Now, you all will know elbow joint can have only posterior dislocation because the capsular ligament is thin at the posterior aspect, and even the ulnar collateral ligament, the posterior band is thin, so posterior dislocation is possible. If somebody asks you why anterior dislocation is not possible, because the anterior bands arising from the ulnar collateral ligament is very thicker or stronger, so that it is not possible. It's very simple. Now, the lateral collateral ligament, nothing much to talk about. It is going to arise from the lateral epicondyle to the annular ligament. I have spoke about the annular ligament already. right? So this is about the ligaments. Yes, capsular ligament, you have to know how it goes. What is the path taken by the capsular ligament? Then about the ulnar collateral and the radial collateral ligament. Yes, very clear? Yes. Now relations. Relations, this is the picture that is being given in your textbook, but I want you all to relate. Yes, for that I got this picture. Now if you take, this is the anterior view of the elbow joint. Yes, what is this fossa called here? So this is my elbow joint. What is this fossa? As you all know, cubital fossa. And you all know the contents. We saw it as a separate video. So all the contents of the cubital fossa is going to be the anterior relation. Right. If you take the posterior relation, as you will have the triceps tendon. So this is the elbow joint, as this is the elbow joint. And if you take, you'll have the triceps tendon, and you have got something called anconeus muscle, would have been discussed in the forearm muscles, right? Anconeus muscle extensor. You have got the anconeus muscle. And if you take in the medial aspect, what you will have in the elbow joint is you will have the common flexor origin, because all your flexor muscles are going to arise from the medial epicondyle, which has got a common flexor origin. Similarly, laterally, if you take, what you will have all the extensor origins. Right, all your extensor muscle have got a common extensor origin on the lateral epicondyle side. This is the relation, right? So kindly orient. This is the anterior view where I've got some muscles like the brachialis, the biceps tendon. So the contents of cubital fossa and simple. Posteriorly, if you take, I've got the triceps tendon, the anconeus. Medially, I've got the medial epicondyle. So I can talk about the tendons, flexor tendons, the common flexor origin. And lateral aspect, I can talk about the extensor origin. I hope you got oriented to elbow joint. With that orientation, come to this picture. So if you take the anterior relations, as it is formed by biceps tendon, brachial artery, median nerve. Yes, these are all contents of cubital fossa. You would have studied 𝐵𝗶𝗴𝐻 from medial to lateral aspect, right? So median nerve, brachial artery, biceps tendon. Along with that, you have got the brachialis muscle that forms the anterior relation. If you get to this picture, as this is the brachialis muscle, can you appreciate it has come anteriorly to the elbow joint. So these four structures, three B's, remember like this, three B's, brachialis muscle, biceps tendon, brachial artery along with median nerve, forms the anterior relation. Posterior relation, again I told from this picture, right? You have got the triceps tendon, you have got anconeus, and you have got nerve to anconeus. Nerve to anconeus, if you take, it is a branch from radial nerve. We have got separate video will be dealt around Thursday, where we'll be talking about radial nerve. Friday we'll be talking about median nerve. I have taken these two sessions, right? So there we'll be dealing about the branches. So nerve to anconeus is from radial nerve. So these three structures are going to form the posterior relations. Next is the lateral relation. As I told you, I've got common extensor origin, and medial relation, you have got the common flexor origin along with something called ulnar nerve. Ulnar nerve is again a separate session dealt by one of our volunteers. So there he will be explaining you about the ulnar nerve. So ulnar nerve forms the medial relation, right? So along with common flexor origin, you have got the ulnar nerve. So median nerve forms the anterior relation, ulnar nerve forms the medial relation, one of the branch from radial nerve forms the posterior relation. Very simple. Yes, these are the relation. Now movements. Movements, if you take, I told you in the very first slide, it is a uniaxial joint. So you have got only limited movement. So flexion and extension is possible. Now you all know we have spoke about the muscles related to elbow joint, anterior relation, brachialis, then biceps tendon, brachioradialis, all these are related to anterior aspect. So all these muscles are going to help in the flexion of elbow joints. All your brachialis muscle, brachioradialis, biceps, all these are responsible for flexion. For extension, yes, it's your very obvious triceps and anconeus. So these are the muscles responsible for extension of the elbow joint. So triceps and anconeus responsible for extension of the elbow joint. Brachialis and the biceps are responsible for the flexion of the elbow joint. Now, blood supply, as I told, it's a very important short note. Now, if you take, what I want you to understand is there is a rich anastomosis around the elbow joint. Can you appreciate? Now, along the lateral epicondyle, I've got some anastomosis. Along the medial epicondyle, I've got some anastomosis, right? So on the front of medial epicondyle, I've got an anastomosis. On the posterior aspect of the epicondyles, I've got the anastomosis. So we are going to see what are the anastomoses that are there. So this is the picture that you have to follow, right? So I will have basically two landmarks, an important 𝗹𝗏 question, medial epicondyle and lateral epicondyle. right? Medial epicondyle and lateral epicondyle. And in the medial epicondyle, you have to know anastomosis that is formed on the front aspect of the medial epicondyle and behind. Similarly, in front of lateral epicondyle and behind the lateral epicondyle. It's very simple. Listen to the picture. Now, this is the medial epicondyle. This is the front aspect, right? Anterior aspect of the front aspect. And this is my posterior aspect or behind the medial epicondyle. If you take the front of medial epicondyle, yes, if you take the front of medial epicondyle, it is mainly formed by inferior ulnar collateral, right? Inferior ulnar collateral. If you can get to the picture, yes, can you see? This is the inferior ulnar collateral. This is the superior ulnar collateral, right? So if you take, they are the direct branches from brachial artery. This is the brachial artery. From the brachial artery, I've got two important branches: the superior ulnar collateral, the inferior ulnar collateral. So the inferior ulnar collateral is going to come along the anterior aspect of the medial epicondyle. The superior ulnar collateral is going to go along the posterior aspect of the medial epicondyle. Yes. So the front of the medial epicondyle, if you take, yes, it is coming as mainly it is formed by the inferior ulnar collateral. When it is coming, it is going to receive a branch from superior ulnar collateral. Yes, can you appreciate? This is the superior ulnar collateral. It gives a branch here, right? So the front of the medial epicondyle, if you take, it is formed by the inferior ulnar collateral and superior ulnar collateral branch. This is from the brachial artery plus a branch from ulnar artery. So what is the branch from ulnar artery? Is the anterior ulnar recurrent artery, right? Anterior ulnar recurrent. So if you take, this is the ulnar artery. From here you have got a branch, anterior ulnar recurrent. Yes, if you get to this picture, yes, you have got the anterior ulnar recurrent. And this is going to fuse with the inferior ulnar collateral. When the inferior ulnar collateral comes, it receives a branch from the superior ulnar collateral. So inferior ulnar collateral and a branch from the superior ulnar collateral forms anastomosis with the anterior ulnar recurrent artery on the front aspect of the medial epicondyle. It's very simple. Now let us get to behind the medial epicondyle. If you get behind the medial epicondyle, it is predominantly formed by the superior ulnar collateral, and when it comes, yes, it receives a branch from the inferior ulnar collateral, right? So it receives a branch from the inferior ulnar collateral along with the posterior ulnar recurrent. So behind, which means what? Posterior. So it formed by the posterior ulnar recurrent artery. Front, anterior. So it formed by the anterior ulnar recurrent artery. So if you take, yes, here you will have the posterior ulnar recurrent, which comes from the ulnar artery, and this is the superior ulnar collateral. It receives a branch from the inferior ulnar, and it comes an anastomose. So this is with respect to the anastomose along the medial epicondyle. Now coming on to lateral epicondyle, very simple. Now if you take the, for the lateral aspect, you have got branches from profunda brachii artery. Profunda brachii artery, again, it's a branch of brachial artery. Now you will have a separate session on arterial supply of upper limb next Monday, that is on May 3rd, by Samyukta. She'll be explaining you very beautifully about the entire arterial and the venous drainage. So there they'll be explaining you about the profunda brachii artery. So just know the brachial artery immediately gives rise to a branch called profunda brachii artery, which gives rise to anterior descending branch and the posterior descending branch. So if you take the lateral epicondyle, in the front of the lateral epicondyle, the anastomosis is formed by the anterior descending branch from the profunda brachii artery along with the radial recurrent artery. Yes. Now if you take, this is the front aspect. So it has complete, very simple, right? The anterior descending branch along with the radial recurrent artery. But if you take behind, see, it goes like this, right? So you have got the posterior descending branch, then you have got the intraosseous recurrent, and you have got some branches from the common intraosseous artery. So this is the common intraosseous artery, this is the posterior intraosseous artery, and intraosseous recurrent artery is a branch from the intraosseous arteries. So the behind the lateral epicondyle, it is formed by the posterior descending branch plus the branches from the intraosseous artery, right? Branches of intraosseous artery, right? So this is about the blood supply. If you have any doubts, you can just rewind the video and listen, because I want to get to clinicals. We have got lots to be explained, right? Please kindly listen. I'm really sorry. Now supply, as I told, different videos we have got. So basically, no nerve supply. I've got radial nerve, ulnar nerve, medial nerve, right? Very simple. That's it. Now coming on to clinicals, as I told, the purpose of me explaining anatomy of elbow joint for this much of time, almost around 15 to 20 minutes, was to make you understand the clinicals. Very simple. Let me tell. Now, before that, it's not actually clinical, but a very common phenomenon is found in majority of the population, that is called carrying angle, almost in everybody. What is this carrying angle? Yes, this is the long axis of the arm and this is the long axis of the forearm. Now, if I have the elbow extended, okay, if I have an extension of my elbow, I'm able to appreciate that the long axis of the arm and the long axis of the forearm has got a minute deviation. Can you appreciate this? This is the long axis of the arm and this is the long axis of the forearm. Now it shows a slight deviation. This deviation is called as carrying angle. Normally, if suppose I would have added in a normal position, right? If it is a fully flexed elbow, then the long axis of the arm will be continuous with the long axis of the forearm like this. Can you make out? But here if you take, what happens? The long axis of the arm is deviating, or I can say long axis of the forearm has slightly deviated from the long axis of the arm, right? So forearm long axis is, it is in this direction, long of the arm is in this direction, so it shows a mild angle deviation. That angular deviation is called as carrying angle, right? This is, you have to know, so this is mostly observed when observed when the elbow is in extended position. Very important. So if an elbow is in fully flexed position, you will not be able to observe this because the long axis of the arm and long axis of the forearm will coincide, right? Yes. Now getting on to radiological pictures, the very first thing that I want to tell is not that important, but elbow effusion. So whenever you have got effusion on a joint, it is basically because of an infection or an injury, right? These are the most common cause of an effusion. Basically, there is some leakage from the joint cavity. Now, if you take, can you appreciate this? This is the ulnar bone, this is the head of the radius, and this is the I can say this is the trochlea and this is the trochlear knot. So this is the elbow joint and this is the posterior aspect. Can you appreciate this blue one? As these are all the effusion. So the effusion is most common on the posterior aspect of the joint. Why it is common along the posterior aspect? Can you appreciate the joint is not shown along the anterior aspect? It is shown only along the posterior aspect. Right? Can you appreciate this? It is only along the posterior aspect. Why not? Yes, you all know the reason, because the capsule is thin on the posterior aspect. So the effusion, the fluid will easily escape along the posterior aspect. Right? So effusion, as I have to know, take out all the fluids. So how I will take out all the fluid is what I will do. I will ask the patient to have the elbow at 90 degree. Okay, so I will have the patient to have the elbow at the 90 degree. Then I will inject along the head of the radius. On the lateral aspect, I'll be injecting a needle and I'll aspirate the extra fluid. Right? So elbow effusion most common along the posterior aspect. So I can easily effuse all the fluid along the posterolateral aspect. So posterolateral aspect means along the head of the radius, I'll insert a needle and you will eject all the fluid out. Yes, so this is the elbow effusion. Next one. Yes, very clear. This is the posterior dislocation of the elbow joint. Now, you all should not get confused with this X-ray. Should not ask me, sir, the humerus had gone forwards. So shouldn't you call this an anterior dislocation? Why you are calling it as a posterior dislocation? That's a very common doubt that you all will have. But what I would like to tell here is, here the dislocation is not with the humerus, but instead it is with the trochlear knots of the ulna. So what happens? The trochlear knot should have been like this, right? The trochlear knot should have been like this. But what had happened, because of some injury, the capsular ligament along the posterior aspect had been torn. Yes, along the posterior aspect had been torn. So what happens? Now the ulna had moved like this. So ulna had moved posteriorly. So the posterior support had completely gone. So suppose if ulna would have been here, this would have been my posterior capsular ligament. So this had completely been torn. So what will happen now is the ulna will automatically go along the posterior aspect. So this is the posterior dislocation of the elbow joint, which is very common. Again, why it is common? Because the capsular ligament is thin along the posterior aspect. Now, should I stop my understanding here? No. Right? I should not stop my understanding here. Why? Because I have to fix this. Right? You would have seen some sports person. They will immediately come. They will do some what to say, fixation, and they will go. Right? Mostly, all these dislocations are common with sports injuries. Right? So immediately there will be a physiotherapist or a doctor who will come and fix the joint. So how do they fix this? Now I need to understand the course of dislocation. Right? If you take the course of dislocation, it is mostly seen in an outstretched hand, in an extremely extended elbow. When I extend my elbow beyond my limits, as posterior dislocation is very common. So what will the physician do? Is if he wants to reduce this joint or place the joint back to normal, what he has to do? He has to do the opposite of it, as he has to flex the elbow. Yes, he has to flex the elbow. Right? He has to flex. Right? This is the posterior dislocation. Can you appreciate this? This is what I want you all to understand. So this is not the anterior dislocation, but the posterior dislocation, because the trochlear notch had come out of this trochlea, and the coronoid process is also dissociated from the coronoid fossa. So if an hand is completely outstretched or extended beyond the limits, then we get posterior dislocation. So how will I reduce the dislocation? Is I go with flexion. Right? Yes. The third one, now coming on to a very important thing, that is called nursemaid elbow or pulled elbow. Very important. Now, what is this? Why it is called nursemaid? Because the culprits, I cannot say they are culprit, but this phenomenon is usually seen in children who are under the care of maid. Right? No, you would have seen, right, in lots of houses, both the parents will be working, so they will have a maid appointed who will take care of cooking, other household, along with taking care of their babies. Right? So if suppose baby is playing and the maid wants to feed the baby, what she will do is she will try to pull the baby through the hands. Right? She will pull the baby by holding the hands of the baby. Are you able to understand what I'm trying to tell? So she will just pull the hand of the baby. When there is this pulling force, what will happen is, yes, can you appreciate this slide here? This X-ray that I have put here. Yes, what you can appreciate, this is the ulna, this is the head of the radius. Can you see the head of the radius had completely come out? Right, the head of the radius had completely dislocated. Can you appreciate this picture also? The head of the radius is not in complete contact with the elbow joint at all. So what happens when the maid, she pulls the hand of the baby? When it is most common is when the baby's hand is in complete pronation. When the baby is completely pronated, say for example, the baby is sleeping and she is trying to lift the baby with arms, right, by holding the arms of the baby in pronated state, what will happen is this kind of dislocation is common. That is, the neck of the radius is completely dislocated, or it is coming out of its joint articulation. That is called as the nursemaid elbow or the pulled elbow. Can you appreciate this? Here you have got proper attachment of the head of the radius with the ulna, but here if you take, yes, there is some disturbance here, right? There is some disturbance. That is what is called nursemaid elbow or pulled elbow. So it is mostly seen in the pronated arm. So how will I reduce this? I need to get back this radius back, right? So what I have to do? I have to do the opposite of it. What is the opposite? Yes, I have to supinate the elbow. Yes, I have to supinate the elbow and I have to extend the elbow. Right? Because usually the arms of a baby are pronated and flexed. Only in that position the maid is going to lift the baby or pull the baby. So I have to do the opposite. So supination and extension of the elbow. And sometimes we directly, in babies, since all the prominences are easily reachable, I just try to apply a pressure on the end of the radius so that it gets fixed. Right? So these are the possible techniques, right? So why I'm explaining you all this, I'm showing a radiograph, is because how to reduce such dislocations, such accidents that happen, right? Yes. I hope you are clear. Next one is two important situations: tennis elbow, golfer's elbow. Tennis elbow is lateral epicondylitis and golfer's elbow is medial epicondylitis. Basically, tear in a tendon. So if you take tendons that are related to lateral epicondyle, mostly the extensor tendons, if they are injured, it leads on to a condition called tennis elbow. If there is tear in the tendons along the medial epicondyle, mostly the flexors, then there is something called medial epicondylitis, or I call a golfer's elbow. Again, after the sport play, right? Tennis elbow, this lateral epicondylitis is most common with tennis people, and this is most common with the golfers people, right? So because tennis people, they usually tend to extend their elbow, right? When they have to have a forehand shot or a backhand shot, they have to extend the elbow. Whereas golf is with no flexion of the elbow, right? You all know about golf. If you would have seen this 𝗏𝗏 Arambam, they would have shown in that song, right? So they have to flex the elbow. Whereas if you take tennis, you have to extend the elbow for no forehand and the backhand shot. So that is why it is most common there. Now, why I have put this picture is we have got one more clinicals. I hope you are not in the situation and listening to Karthikeyan's lecture, right? Oh my God, he's trying to extend the session. So I hope you do not sit in this position. If you sit in this position, you are going to have a condition, serious condition. What is that condition? Yes, last slide. Can you appreciate? Yes, she's having severe headache. Probably you could have been in this position. You are listening to Karthikeyan's lecture here and you are having a headache and you rest your elbow on the table. Right? You are completely fed up with my teaching. You are resting your elbow on the table. So you are showing all the frustration and angry on me to your elbow, which strikes the table. So what happens if you do so is you have got some bursa that covers the joints. Okay. Bursa, you have got a subcutaneous bursa, subtendinous bursa around the elbow joint. So what happens when you are going to do this, you're going to apply pressure on the bursa, on the subcutaneous bursa, there's an inflammation. So there can be some injury to the bursa, there's an inflammation that can present as severe pain. So most commonly it's the oligoclonal bursitis, subcutaneous oligoclonal bursa that gets infected and you get something called oligoclonal bursitis. That is very, very, very common, right? So that's all. With this I have done. Sorry I did not put a thank you slide. I'll come to that. Most important thing you have to know is the nursemaid or elbow or the pulled elbow. They can even ask you in MCQs, what will you do? How will you reduce? Yes, this is seen mostly in babies who have been pronated and flexed. So what I have to do, I have to supinate and extend the elbow. Posterior dislocation is I have to flex the elbow on the forearm. Yes, right. This is the important thing that I want to get you. So if you appreciate, only if you know the bone, the landmarks, all that, you'll be able to interpret the radiography. So this is the normal elbow joint, right? With this is the ulna, this is the radius, here you have got the coronoid process, this is the trochlear notch. So only if you know the anatomy, you'll be able to study the X-ray. It's very important, right? So I hope I made this session better. I hope you are not there in this position, right? At least if you're there in this position, please know you can have a subcutaneous oligoclonal bursitis, and I request you all to take off your hands, right? With this, I would like to conclude my video. Though it was a bit longer, around, I guess around it would have come around 40 minutes, but it is worth watching, right? You will never forget elbow joint if you have understood the ligaments, if you have understood the position and the clinicals, right? I'll meet you in some other video. I'll be taking nerves of upper limb. Until then, take care. Tata, bye. Keep supporting us. Tata.